Hi everyone, welcome to Medic's Corner. Today we'll be discussing pulmonary embolism. The main focus of today will be treatment and management of pulmonary embolism. Treatment of a pulmonary embolism. If a patient is suspected of having a PE, we start interim anticoagulation therapy while carrying out investigations for pulmonary embolism. The investigations include a full blood count, renal and liver function tests, prothrombin time, and activated partial thromboplastin time, as well as a CTPA if indicated by the Wells score. Following this, we review the results from the blood test and if necessary act on the results within 24 hours of initiating interim anticoagulation. Stop interim treatment if PE is ruled out on investigations. Treatment of a confirmed PE. This is treated with anticoagulation for greater than 3 months. In deciding the treatment, consider comorbidities such as extremes of weight, renal impairment, active cancer, and triple positive antiphospholipid syndrome. The NICE guideline has recommendations for suitable medications for patients with various specific comorbidities. The discussion on these specific treatment options is beyond the scope of this video. If a patient is on long-term anticoagulation, review the patient after 3 months and consider stopping or continuing anticoagulation. Continue if the patient presented with an unprovoked PE. You will need to calculate the Hess blood score to assess the risk of bleeding for patients on long-term anticoagulation. Discuss stopping anticoagulation if Hess blood score is greater or equal to 4. Another stop criteria is if the provoking factor is no longer present. For example, the short-term provoking factor could be trauma or post-surgical patients. Drug choices. Apixaban or rivaroxaban are the first options. If apixaban or rivaroxaban is not suitable, an alternative could be a low molecular weight heparin for at least 5 days, followed by edoxaban or dabigatran. As a second alternative, offer low molecular weight heparins in combination with a vitamin K antagonist such as warfarin for at least 5 days or until the INR is greater or equal to 2 on 2 consecutive tests. If these criteria are met, continue with a vitamin K antagonist on its own. The reason for using a low molecular weight heparin initially is because warfarin has a long half-life, hence it takes longer before it starts to have an effect. A low molecular weight heparin is therefore needed to provide an almost immediate anticoagulatory effect in the meantime. Sometimes there's a need to thrombolyze patients with a confirmed PE. This is indicated if the patient has worsening right ventricular strain plus an increased oxygen requirement despite anticoagulation therapy, or patient presents with hemodynamic instability, which involves a blood pressure of less than 90 systolic for greater than 15 minutes, or patient presents with a cardiac arrest with a confirmed PE. Please like and subscribe to my channel. Thank you for watching Medic's Corner.